Hi, my name's Travis, and today with 10 Minute Medicine, I'm going to take you through an upper GI bleed that you've been asked to go and see. So, when seeing an upper GI bleed, it's one of the presentations that can deteriorate really quickly, and you should always use an A, B, C, D, E approach. And it's really important if you identify any early issues with the airway, breathing or circulation that you stop what you're doing and put a 222 call, or however you make an emergency call in your hospital to call for an arrest team, because you're going to need more help to treat this patient. Also, if you find an airway issue, it's important to use the manoeuvres and adjuncts that you've been taught. This can include a head tilt chin lift, the insertion of a nasopharyngeal, oropharyngeal or even i-gel into the airway, and supporting the breathing and circulation as you've been trained to do so. It's worth noting at this point that upper GI bleed patients can deteriorate very quickly, and so if you suspect this is going to happen, it's important to call for help early instead of letting the patient deteriorate and having to then put out an arrest call. So the emergency management of an upper GI bleed is going to happen extremely quickly. The first thing you'll want to do is lay the patient on their side. If they're vomiting, the worst thing that can happen is that they start to then choke on their own vomit, as this will just complicate matters, and in a true upper GI bleed, sadly also won't stop further vomiting. Secondly, once they're on their side, you want to apply some oxygen. They're going to be struggling to get oxygen through, especially if they're vomiting blood, as well as becoming more dehydrated and anemic. However, it's really important to mention that while they've got the mask on, you need to make sure that they're able to move it if they feel like they're going to vomit. And if they're not, that somebody's keeping an eye on this, as otherwise they will vomit into the mask and again begin to choke. You need good monitoring on these patients. Ideally, you want saturations, blood pressure, and if possible an ECG to be monitoring constantly. If you've got this facility, don't let anybody take it away. Once it's on the patient, leave it there. The next thing is that you need good IV access. If these patients are a true upper GI bleed and deteriorate quickly, we're going to want to rapidly infuse fluid and blood. Aim for a large cannula, ideally green or above. However, I would say at this point that any cannula is better than nothing. And so if you don't feel like you're going to establish large IV access, put in what you feel like you can, call for help, and let somebody else do it. There's nothing worse than coming to see a patient who's got no veins left because they've all been blown and also has no IV access. When you get the cannula established, make sure to also take blood. And it's really important that this includes a group and save, because we may need to give patients back blood. Once you've got IV access, give a litre of saline stat to replace the blood that you've lost. This obviously assumes that the patient is bled a lot. If it was a small amount of blood mixed in with vomit, then you may not need quite as much fluid, but assess the patient in front of you. It's important to take a quick history. Try to identify why they've started vomiting blood. Has this been a small thing that's developed over time, or is this a sudden onset large GI bleed? You also want to do a quick examination that should include the heart, lungs and abdomen. That being said, you don't want to carry this out like a medical school examination, starting at the hands and working up. We need to rapidly establish what the situation is with the lungs, the heart, as well as the abdomen. And then you want to rule out any life-threatening causes, which we'll go through now. So the big four that you need to look out for are a peptic ulcer, gastroesophageal varices, vascular malformations, or an upper GI malignancy. And so it's worth just going through in your head what would cause each of these. With a peptic ulcer, you're looking for either excessive NSAID use, being a common one, history of H. pylori infection, or previous OGD showing peptic ulcers. With varices, this may be from repeated coughing or vomiting. Vascular malformations we won't know about until the patient identifies them, but an upper GI malignancy will have the typical signs of cancer. Okay, moving on to the secondary management of the upper GI bleed. These are all the things that you're going to do, not emergently when you arrive, but as soon as you've established that the patient is at least in a stable position that doesn't require an immediate intervention. First thing we're going to do is have a look at any recent bloods that we've got. And if they're within the last couple of days, we're going to look for any clotting abnormalities. The patient may have very low platelets or very high APTT. Similarly, if you notice that the patient at this point is still continuing to vomit and large amounts of blood, again, I would just stress it's worth calling for help early. have a look at the HB that you get back on a VBG that you've done, because that will give you an idea of what the current HB is if they've been bleeding for a little while. It is, however, worth remembering that immediately after the upper GI bleed, the haemoglobin won't be represented accurately on a VBG. And so again, it may be worth discussing whether or not there's a role for giving blood early. We ideally want to give patients cross-match blood, but the likelihood is the results won't be back from our cross-match earlier. And so we will have to give O negative. It's worth pointing out at this point that most hospitals will have a major hemorrhage protocol. And so if there is absolute large amounts of blood coming out of the patient, you can put this out as well as the emergency call to ensure that blood is made its way to where the patient is quickly. Again, I just wanted to stress that you may need to contact an on-call endoscopist. However, this is a decision I would make with the medical registrar or intensive care. And as an F1, it's not a phone call that I would make yourself. You can, however, calculate a Glasgow-Blatchford score or a Rockall score. And it's worth checking in your hospital which one you tend to use and what the endoscopist is likely to ask for. We'll go through exactly what this is, and then if non-acute and settles, it's worth also following up with an OGD within working hours. So the Glasgow-Blatchford score is the most commonly used scoring for an upper GI bleed. And all you do, this is straight from MD Calc, is pop in the patient's haemoglobin, urea, and initial systolic blood pressure when you arrived, as well as their gender, and then their heart rate, whether there's any melena, any recent syncope, hepatic disease or cardiac failure. And you can see that each of these add a certain score, and the HB urea and systolic blood pressure will also generate a score. This is something you're very likely to be asked for if you do have to call an endoscopist, and is a great way when you're communicating the severity of an upper GI bleed to anybody else, just to know. So in summary, upper GI bleed patients tend to be very sick, and they are patients that you're likely to need help with. Anybody who's having persistent hematemesis and not just a one-off incident is likely to need review by a senior doctor. However, all the things that we listed are things you can do even while help is on the way. The most important is establishing good IV access. However, remembering what I said about any access is better than none, and so getting the access that you feel confident that you can establish, because later on the help may be able to put in bigger access if we're able to rehydrate them. However, as the patient becomes more dehydrated from the bleeding, IV access will become more difficult. Make sure you've got a secure airway and that their breathing is secured. And if you're unsure what to do with a patient with low SATs, we have a video on that you can watch. Always try and calculate your scoring criteria, and especially if you're the one who's been tasked with calling the on-call endoscopist, make sure you've got a good history of what's happened, the amount of blood that's been produced, and the GBS score, if that's what your hospital uses. Finally, just to note, most hospitals will have an upper GI bleed policy. And again, it's worth just having a look through this prior to being called to see an upper GI bleed, just so you're familiar rather than in an emergency not knowing exactly what to do. And certainly if you get a patient that's bleeding but isn't in an emergent state, and so you have a little bit of time, you can always know where this is so that you can review it at the time. However, hopefully this video is giving you an overview of exactly what you can do, the emergency things you need to do and when to call for help, and I hope it'll be useful for you as an F1. Thank you for listening, and please check out a lot of the other 10-minute medicine videos that will help you support through your F1 year. Thank you.